Assalamu alaikum wa rahmatullah. My name is Amani Hamza Osman. We are here to continue the topic of epithelial pathology today with the second lecture. So without further ado, let's just dive into it. So we will start by going through the classification of epithelial pathology once again, as we did in the first lecture. Following that, we'll have some definitions about today's topic and some examples. And we will discuss in a little bit more details some examples from epithelial premalignant lesions and some examples from epithelial premalignant conditions. So if we look at the sum of epithelial pathological conditions or diseases, we can divide them into four main categories. First, epithelial non-odontogenic lesions. And you have to remember here that we're speaking about the oral cavity conditions. And that's why we mentioned non-odontogenic. So it's not actually related to the structure of the tooth or the tissues that are forming the tooth, but they are rather found in the oral cavity. So the second category is benign epithelial non-odontogenic tumors. And these first two categories have been discussed in the first lecture. You can always refer to that first lecture for review. The third category is epithelial premalignant lesions and conditions, which is the topic of today. And finally, we have malignant epithelial non-odontogenic tumors, which is the topic of the fourth lecture. The third lecture. Now we move on to some definitions. We'll start with the precancerous lesion. A precancerous lesion is a morphologically altered tissue in which cancer is more likely to occur than in its apparently normal counterpart. So it's usually confined to a specific location or a specific organ or tissue, which has a morphological alteration or a change in shape or appearance. While the definition of precancerous condition says that it is a generalized state of the body, which is associated with a significantly increased risk of cancer occurrence. So it's not only specified or localized in one place, it is generalized to the whole body. Examples of these diseases that we can discuss some of. For premalignant lesions, we have a condition known as leukoplakia. We have erythroplakia. We have carcinoma in situ. We have Bowen's disease. We have actinic cheilitis, and we have dyskeratosis follicularis. These are some of the conditions, some of the lesions. And in terms of conditions, we can see oral submucous fibrosis, oral lichen planus, syphilitic glossitis, sideropenic dysphagia, and dyskeratosis congenita. We will start with the first group, which is premalignant lesions. Leukoplakia. So the term leukoplakia was first coined by Hungarian dermatologist Schwimmer in 1877. And the term originates from Greek language, in which leukos means white and plakia means a patch. So the WHO in 1978 defined leukoplakia as a white patch or black in the oral cavity, which cannot be scraped off or stripped off easily, and cannot be characterized clinically or pathologically as any other disease. Leukoplakia represents a whopping 85% of all oral premalignant lesions. So it is the vast majority of premalignant lesions are actually leukoplakias. Males have the highest incidence with the trend actually changing gradually, because usually these pathological phenomena or lesions are accompanied by environmental factors and lifestyle factors or determinant or hereditary factors and so on. So in the older times, males were the affected by leukoplakia most. We will get to know later because of their habits, which are changing gradually to be common between males and females, for example, tobacco use and smoking. If we looked at the etiology of leukoplakia, we can find two main types. It can be either idiopathic leukoplakia, which means there is no evident etiological factor recognized for it, or it could be non-idiopathic leukoplakia, in which case we have evidence of predisposing factors such as tobacco use, alcohol consumptions, bacterial infections, fungal infections like candidal infections, viruses, and sanguinaria. Sanguinaria is a herbaceous flower plant that is used as a toothpaste or mouth rinse in some part of the world. And it was related to development of true leukoplakia. This type of leukoplakia was called sanguinaria-associated keratosis, and they usually arises in maxillary vestibule or in the maxillary alveolar mucosa. So it is considered one of the predisposing factors for the development of leukoplakia. The clinical presentation of leukoplakia, it can occur in any mucosal surface. It can be a single lesion, solitary, or multiple white patches. So it varies in the number of lesions. It also varies in the appearance from a non-palpable, faintly translucent white area to a thick fissured papillomatous or indurated lesion. So it does not have a typical shape. It has a variety of shapes, which usually makes the job of a dentist a little bit more challenging, because if you have a unique feature that you are quite sure about, it will be easy for you to diagnose. But if it has several appearances or non-specific appearances, you will have a harder job of trying to recognize it. The color as well varies from white to gray to yellowish white, sometimes even brownish yellow. As with most oral white lesions, the clinical color results from a thickened surface keratin layer, which appears white when wet for the naked eye, and it appears quite red under the microscope. 70% of leukoplakias are found in buccal mucosa, commissural areas, followed by the lower lip, floor of the mouth, palate, and gingiva. And it usually affects persons older than the age of 40, but it's not a fixed rule. It's a generalized note or a generalized observation. We have four typical morphological appearances of leukoplakia. It starts as a mild or thin leukoplakia, which seldom shows dysplasia on biopsy, and it may disappear or continue unchanged, or it might sometimes progress to a more advanced stage. The next stage is called thick leukoplakia or homogeneous leukoplakia, which, if smooth, it remains indefinitely at this stage, or it could also progress to a more advanced stage, which is the granular or nodular leukoplakia with increased surface irregularities. So the smooth appearance will disappear, and it will be replaced by a more roughened surface or granular surface. And finally, the most advanced type of leukoplakia is the verrucous leukoplakia or verruciform leukoplakia, which demonstrates sharp or blunt projections, and it has a finger-like appearance or projections. However, leukoplakia may become dysplastic, even invasive sometimes, even with no change in its clinical appearance. So it's of detrimental to ignore or the importance of histological examination. You have to do histological examination because leukoplakia can appear very innocent, thin, small, thin leukoplakia, while it is actually an invasive lesion or frank cancer. You always have to weigh the two appearances, the clinical appearance and the histological appearance. So this picture here shows you all 4 types that have been discussed before. This is the first type, which is the thin leukoplakia. It's quite small. The surface is smooth and does not have any suspicious appearance or alarming appearance. It could stay as it is, or it can regress or disappear if the patient stopped the habit that started the whole thing, if it's related to a habit, or it can progress to the thick type, in which you can notice the surface area had been enlarged. Also, it became quite thicker. So you would imagine that keratosis in this area has also increased, and the thick can stay as is indefinitely, forever, as long as the patient lives, or it can progress, but it cannot go back to thin. So the thick can stay as is, or it can progress to the next type, which is the nodular. The nodular is, as the name suggests, it starts to become rough on the surface, and it is a little bit, it has more tendency to become dysplastic. Finally, the verruciform. Verrucous appearance is like the cauliflower or finger-like projections, and you can see it in the surface of the tongue here. It's quite alarming, and it's clinically very suspicious. So in any case, don't depend on the appearance on a clinical examination alone. You have to look at the histological appearance. In this picture here, we have a composite representation of the various phases or clinical appearances of oral leukoplakia with anticipated underlying histopathologic changes, just to give you an idea about what might happen progressively from the start to the end. So the lesions have increasing malignant transformation potential as their appearance approach those towards the right. It starts from the normal mucosa in here. Everything is fine. Epithelium thickness is as it should be. And then we have the appearance of thin, smooth leukoplakia, in which we can see more, in some cases, we can see candida hyphae, maybe, and congested vessels in this area. Moving on to thick fissured leukoplakia, the amount of hyphae might increase, and the amount of congested vessels will increase as well, and the surface area will become more thick. Moving on to the granular or nodular and verruciform, we can see the surface area became bigger, and the changes in the underlying connective tissue and epithelial layers also is more evident. We did not discuss erythroplakia yet, but this is a more advanced, dangerous, with a very high potential of malignancy transformation. It is called erythroplakia. Erythroplakia in this stage is not a complete erythroplakia, it's speckled erythroplakia, or speckled leukoplakia. It means it's a mix between white patches and red patches, because the epithelium has become very thin in some areas or disappeared altogether. And this is this should urge you to investigate if there is any invasion, because speckled leukoplakia or erythroplakia and complete erythroplakia are very, very prone to become frank cancer. So usually we look at specific clinical criteria for high risk of malignant changes. If we notice erosion or ulceration within the lesion, if we have a nodular type of leukoplakia, also a lesion that is hard in its periphery is very, very alarming. a lesion of the anterior floor of the mouth and the undersurface of the tongue are usually more related or prone to malignant transformation. In all cases, however, the relative risk of malignant potential is mostly determined by the presence of epithelial dysplasia upon histological examination. So there is no escaping the histological examination to be able to determine 100% that there is epithelial dysplasia. We will discuss epithelial dysplasia later on. So the histological appearance of leukoplakia, we always notice from the thin type to the very thick verrucous type, there is a thickened keratin layer of the surface epithelium, which is called hyperkeratosis. So there is an increased production of keratin with or without a thickened spinous layer, which is the layer under the corneated surface of the epithelium. And if we have a thickened spinous layer, this is called acanthosis. So we have always hyperkeratosis with or without acanthosis. Frequently, there are variable numbers of chronic inflammatory cells noted within the subjacent connective tissue, reflecting the amount of reaction from the body to this leukoplakia. If you look at the hyperkeratosis, it can be either hyperparakeratosis, in which you can notice the nuclei on the surface of the epithelium, or hyperorthokeratosis, in which we cannot see the nuclei. So both of them are increased amount of keratin, but in parakeratosis, the nuclei are present. In orthokeratosis, they are absent. Sometimes you can actually see a combination of both. Evidence of epithelial dysplasia is found in only 5% to 25% of cases of leukoplakia if we consider all the oral sites together. But in my opinion, 25% of the cases is quite high. So quarter of the cases that we can see with leukoplakia can become actually cancer. So this is quite high. If we zoom inside the epithelium to see alterations or dysplastic changes that we keep talking about, which is an indication of the beginning of the malignant transformation or the high potential of malignant transformation, we can see specific changes happening inside cells of the epithelium or inside the layers of the epithelium that lie on top of each other. These changes have been similar between leukoplakia and squamous cell carcinoma. So the changes are not specific to cancer alone or to leukoplakia alone. It can be similar in the two cases, and hence we always are afraid that this might become oral squamous cell carcinoma eventually if we have it. So you will notice in large nuclei, also in large cells, that the cells are larger than you expect them to be. Also large and prominent nucleoli, which is the subnucleus part. It appears like small dots inside the nucleus. Usually they are not very easy to see with the light microscope, but in case of epithelial dysplasia, they become large and very dark and prominent. You can see them easily. There is also an increased nuclear to cytoplasmic ratio, or as we know it as NC ratio. And this means that the size of the nucleus will become larger than the normal size. So it will tip off the balance between the amount of nucleus and cytoplasm inside the cell. We also notice hyperchromatism, which means excessively dark staining of the nuclei, which makes them very, very dark. And we notice pleomorphism of the nuclei and cells, and pleomorphism means abnormally shaped nuclei and cells. The dyskeratosis is not only an increase in the amount of keratin, but it's also faulty or premature keratinization of individual cells. So sometimes the keratin will start earlier than it should start, because all the keratin in the normal situation should be on top of the epithelium, But in case of dysplasia, you can see individual cell keratinization beneath the surface area, which is called dyskeratosis. We have an increased mitotic activity, and this is represented by excessive number of mitoses throughout the epithelium, as well as abnormal mitotic figures. So it's not only an increase in number of mitoses or cell division, but this cell division sometimes is abnormal or atypical. So you would see tripolar, giving not only 2 cells from 1 cell division, but 3 cells, which is called tripolar division. Sometimes you will see star-shaped mitosis given 4 cells out of 1 cell, or mitotic figures above the basal layer, which is very abnormal for the epithelium because the area that is very specified for mitosis is the basal cell layer and only 1 or 2 layers above that. But in the case of dysplasia, you can see the mitotic figures up high in the epithelial layers. So these pictures here represent the condition that we're talking about. The first one here represents hyperkeratosis. So there is no actually dysplasia in here. It's just an increased amount of keratin on top of the epithelium. And you can see that the epithelium is working very hard to produce these keratin. And that's why we see very dark staining here, which means these cells are active in producing this protein, but it's immature here. Once it matures, it becomes this red in color. Here we see the beginning of dysplasia. So that's why we call it mild dysplasia. It only occurs in these basal cell layer and the 2 layers above it. You can start to notice that the nuclei here look a little bit darker in color. They are not exactly the same size as we can see here. Here, all the cells are basically the same size. But here you have some cells that are larger than the others. You have some cells that have darker nuclei, and the connective tissue underneath, it contains a little bit of inflammatory cells that these are the dark dots that you can see under the epithelium here. This is a moderate dysplasia, epithelial dysplasia, and the difference between mild and moderate is the thickness or the elevation of the changes. In case of mild, this will be only the basal layer and the suprabasal layers, so 1 or 2 or 3 layers. Here, it can go up to the middle of the epithelium. We can see the changes happening, the change in NC ratio, the change in the size, the pleomorphism, and all that. And this one here is the most scary one of them all, and this is the severe dysplasia, in which the changes are from the bottom of the epithelium to the top. You can actually see nuclei. We can see it's quite rather difficult to see any mitotic figures here, but if we zoom in, I'm sure that we will see mitotic figures sitting up here, which is not normal at all in case of normal epithelium. And you can see the dark dots inside. It indicates hyperchromatism. And so the changes, or the difference between the changes in mild, moderate, and severe, are in the elevation or the amount of changes starting from the base moving up to the top of the epithelium. So what do we do if we have leukoplakia? The first step into treatment is to arrive at a definitive histopathological diagnosis. This is very important because according to your histopathological diagnosis, you'll be able to follow up with the patient or to decide what to do for the patient. So to arrive at this definitive diagnosis, a biopsy is mandatory and it will guide the course of the treatment later on. So leukoplakia exhibiting moderate epithelial dysplasia or worse always warrants complete removal or surgical destruction if feasible, because sometimes, unfortunately, it's found in areas in the oral cavities that's very difficult to operate. Also, the management of leukoplakia exhibiting less severe changes is guided by the size of the lesion and the response to more conservative measures, such as cessation of smoking or changing of the habit. So if you have thin leukoplakia or thick leukoplakia and the patient is willing and able to stop the habit, if it's not an idiopathic leukoplakia, you should start with conservative measures. But if you see nodular leukoplakia or speckled leukoplakia, you cannot just tell the patient to stop the habit and hope for the best, because this is a risky route to go. You have to start planning a removal of this lesion, because it has much higher risk of becoming transformed into cancer. Another one of the premalignant lesions is erythroplakia. So erythroplakia is sometimes they start as leukoplakia and eventually they become or demonstrate scattered patches of redness, and this redness might be called speckled leukoplakia if it is not completely red, and if it's completely red, they are called erythroplakia. The word erythro, it means red, as in the redness that we see in the lesion, because leukoplakia, it means white patch, erythroplakia, it means red patch. So such areas that are reddish inside the oral cavity in oral mucosa, they are usually representing of sites in which epithelial cells are so immature or totally atrophic that they can no longer produce keratin. So they are exposed, or the connective tissue lying underneath them is totally exposed to the naked eye. All the blood vessels pumping the blood are very easy to reflect the red color when you look at the lesion in clinical examination. So this intermixed red and white lesion, as I said before, it's called erythroleukoplakia or speckled leukoplakia. And it represents a pattern of leukoplakia that is frequently reveals advanced dysplasia on biopsy. So in more cases than others, if we have speckled erythroplakia, it will show advanced dysplasia on biopsy. So it is quite alarming, and we should remove it at once if it's feasible. Although erythroplakia is less common, it has much greater potential to be severely dysplastic at the time of the biopsy, or to develop invasive malignancy at a later time. So we always, if we have to choose between leukoplakia and erythroplakia, I think you know now what to choose. The clinical appearance of erythroplakia is predominantly seen in middle age to older adults with no significant gender predilection. So it can occur in males or females. You can see it in the floor of the mouth, in the tongue, soft palate. These are the most common sites. It is usually an asymptomatic, well-demarcated erythematous macule or black with a soft velvety texture. But it's not very unique, because you can see other lesions that has the same appearance in the oral cavity. You should not just rush to the conclusion that this is erythroplakia. You have to rule out non-specific mucositis that may be caused by any type of irritation in the oral cavity. Also, you have to rule out candidiasis, psoriasis, vascular lesions, or any problem in the blood vessels. All of them may clinically mimic erythroplakia. So a biopsy is often required to distinguish between them and rule out or exclude other problems and arrive at your actual diagnosis. This is a picture of 3 cases of erythroplakia. You can see it. This is at the base of the mouth under the tongue. It's mixed between white and red. This here is more reddish, and you can see it in the floor of the mouth. And this here is in the palate, in the back, the area of the retromolar pad area. So again, I want you to look at this representation of erythroplakia and the changes occurring in the histological level, and reflect on that. So again, it's very important to check the histological appearance, just to be sure that what we are dealing with here is actually erythroplakia, and this can help plan out the treatment for the patient. So almost all true erythroplakias demonstrate significant epithelial dysplasia. 90% of the cases of erythroplakia have severe dysplasia, which is not a good thing. The epithelium shows a lack of keratin production, as we mentioned, due to the atrophy or immaturity of epithelial cells. And this reflects the red color very obviously. Sometimes, however, the epithelium can be hyperplastic, but this is not the case in all erythroplakias. Underlying microvasculature shows through, because we don't have any keratin to block out that, thereby explaining the red color. So the underlying connective tissue often demonstrates chronic inflammation. We can see macrophages very massively in these areas, specifically chronic inflammatory cells, not acute. So speckled erythroplakia is the presence of Candida hyphae as well as cellular atypia, and it has a high potential of malignancy. We don't like speckled erythroplakia. This picture here represents 2 cases of erythroplakia. And this one, you can see the amount of changes happening in the epithelium. You can tell immediately that there is something very wrong with this epithelium. The dysplasia is quite massive. You can notice here the nucleoli and the size of the cells, the difference between the cells. This pink small dot here is a mitotic figure. It's quite at the top. It's not supposed to be here. You can see hyperchromatism, and you can see the difference in size between the cells sitting at the base and this cell here. Okay, this is a giant cell. This is here a massive cell, and this is a cell also. And the amount of crowding that's happening at the base here, indicating something is about to happen. So there is no much keratin. We don't see a lot of keratin at the top. And here you see some hyperactivity of the epithelium. So there is hyperplasia, but you also see some keratin at the top, but you can see the differences between the cells. It's very, very obvious. So the red lesions of the oral mucosa, especially those on the oral floor and the ventral or lateral tongue, should be viewed as suspicion, and a biopsy should be performed no matter the case. Lesions exhibiting moderate dysplasia or worse must be removed immediately and completely by surgical methods. Recurrence and multifocal oral mucosal involvement are common, so long-term follow-up is suggested for treated patients. You cannot rule out that something like this will happen again if you treat the patient. You just have to keep following them up for as much as you can. So this is erythroplakia and leukoplakia. We move on now to another example of premalignant lesions, which is actinic cheilosis or actinic cheilitis. This is a common premalignant alteration of the lower lip vermilion border due to long term of excessive exposure to the ultraviolet component of the sunlight. It is confined predominantly to people with light complexion, especially those with tendency to sunburn easily. So it is seen on the fair skin more than the dark skin. Outdoor occupation obviously is associated with this problem, hence the term farmer lip and sailor lip. So if you hear about the term farmer lip or sailor lip, it is speaking about actinic cheilosis in these patients.